Welcome. Welcome to Move to Learn, a Handspring webinars series that is today, Wednesday, March 10th. Our guest is Niall Galloway, Emeritus Professor of Urology at Emory University and the author of Seeking Symmetry, Finding Patterns in Human Health. Before the introduction of Niall Galloway, let's take a look at how things work, what you can expect in this webinar. The webinar will comprise roughly 45 minutes of discussion, presentation, and guided practice, followed by 15 minutes of Q&A. The chat is on, so please do say hello and tell us where you're joining from. We welcome your questions. Please submit these questions using the Q&A button on your screen. We aim to finish on the hour, but we may continue for 10 minutes after the hour to ensure that Niall can answer as many questions as we can. Niall's book, Seeking Symmetry, is poised against my yoga block, and I thought just then that the book was about to take a dive forward into the screen. That's why I jumped for it. We are recording the webinar and we'll share a link to it in the follow-up email, as well as any references or resources that you may be interested in. This webinar is streaming live on YouTube, in addition to being broadcast by Handspring on Zoom. We call your attention to a disclaimer. This discussion is for informational and illustrative purposes only and is not meant to impart medical or therapeutic advice or instruction. I'd like to introduce you to Niall Galloway via his bio now. Dr. Niall Galloway is Emeritus Professor of Urology and former Medical Director of the Emory Continence Center at the Emory Clinic in Atlanta. He joined the Emory University School of Medicine faculty in 1989 with research interests in developmental biology, clinical anatomy, and neuroscience. Dr. Galloway has worked extensively in the areas of clinical evaluation and surgical treatments for congenital and acquired defects of the pelvic support anatomy and urogenital anomalies, and has been active in applying the principles of Biotensegrity to pelvic reconstructive surgery for vaginal prolapse and incontinence. A native of Scotland, Dr. Galloway attended the University of Aberdeen Medical School and completed his training in England. He taught at the University of Edinburgh and University Hospital of Wales in Cardiff before completing a fellowship at Duke University, where he subsequently served as visiting professor. Niall Galloway, welcome. Welcome to Move to Learn.
Well, thank you very much, Elizabeth. It's a great thrill to be here with you today, and I'm most grateful to you for your invitation. I thought it might be helpful to start by just taking a look at ourselves. And one of the easy ways to look at ourselves is to look at our hand. And I would draw your attention to the proportions of the hand, and we might start with the finger. Here we are using a golden section caliper to demonstrate the golden proportions of the distance between the tip of the digit and the length of the finger. This is a very predictable, reliable measure. And if we look a little beyond this measure, you'll find that if we look at the hand, for example, the exact same proportion exists between the length of the palm of the hand from the crease of the wrist to the base of the fingers as to the length of the fingers themselves. So the part that is closest to the body is the part that is longer, and the part that is more distal is a little shorter. And if we go back for just a moment, we can see that if we pull up our sleeve a little, the distance between the crease of the elbow and the crease of the wrist is that same proportion again as the whole length of the palm and the fingers. If we look more closely at the relationship between the little finger and the rest of the fingers, if we straighten the hand out flat, just take a look at one hand first and pay attention to the length of the little finger as it relates to the crease on the ring finger. So we're looking at the smallest finger's length in comparison to its neighbor. You'll see on the screen that this is my left hand, and on my left hand, the little finger comes well beyond the tip of the crease of the ring finger. As you look at your own finger, you may find that your own little finger is rather shorter and that it comes either to the crease or short of the crease. And this will certainly be true if you have a birthday in the months of November or December, or if your mother was particularly young or particularly old at the time of your birth. The same would be true for twins. If you have a twin brother or a twin sister, your little finger will be shorter than the finger that you see in front of you, because your hand is made at the same time as everything else in the body. This tells us not only about our hands, but it tells us about other things as well. So I'd like you to stand up, if you will, and just take a moment to stand on one leg for 10 seconds. And now that you have committed to a leg, just make note whether you're standing on your right leg or your left. And if you settle back down into a more comfortable position and look at the length of your little finger, for those of you whose fingers are not quite exactly the same length, you'll find that almost certainly the leg you chose to stand on was the side of the longer little finger. This is a very predictable finding, and I'll explain to you later why it is that how the hand is made will be mimicked in how the foot is made, and that in turn will be mimicked by how the pelvic floor and the pelvic structures are made. All of these structures are made when you're approximately 6 millimeters long. So that's about 1/2 inch, and not even 1/2 inch, about 1/4 inch long. So putting that to one side, let us move for a moment to think about why we're interested in encouraging you to seek symmetry. Symmetry seeking is a way of looking at the world that is a little different than the way we often are led to look at the world right now. There's a tendency to think in terms of difference, that I am old and you are younger, that I am male and you are female, that I am, of one political party and you are of another political party, for example. There are a lot of these dichotomies, but in reality, to recognize difference, you only need to know one thing about somebody. But to recognize how similar you are, you have to look at a lot more elements. And as you begin to look at the world using the tools of symmetry seeking, you have a very different worldview, a worldview that is much more about how similar we are and what we share rather than how we're different. And with this view of appreciation of how similar we are, the world truly becomes a much better place. But there are some tools that are helpful. One is to make sure that we're looking at the big picture, that we're looking at wholes and not just parts. And in order to see these sorts of symmetry, you have to pay attention to your perspective, and you have to sometimes adjust the scale because you see in one form something that's very similar to another, but perhaps the scale is quite different. One of the examples of that might be to see the form of the leaf of a tree and see that the form of the oak leaf is the same as the form of the oak tree. And the same, of course, is true of beech trees or whatever. The seed only has enough information to make one kind of form, and that one kind of form will be manifest in the leaf and the branch and the whole tree. And everything that we can think about, that we can say in biology that applies to plants, almost invariably applies to animals. And of course, if it applies to animals, it also applies to humans. Another aspect of the symmetry seeking would be to look for function and purpose. What is this doing? What are my lungs doing? My lungs are cleaning the blood and wasting the carbon dioxide in the expired air. And that's remarkably like my kidneys, which are also cleaning the blood, but excreting urine rather than exhaling air. And we find that things that happen in the upper part of the body happen more frequently. So I breathe about 18 times a minute, but I only empty my bladder 5 or 6 times a day. We're going to find the same is true for structures like the thyroid, which is involved with your daily rhythms, your biorhythm, and is to do with growth and development. The thyroid is surprisingly similar to the ovary, which again, this is about daily biorhythm. The ovaries are about monthly biorhythms. And as you will find as you explore this a little more closely, that there are events in nature that will help us to see the way these things are similar. If you have thyroid disease, you often have infertility. The parts of the thyroid are made of follicles, just like the ovary is made of follicles. The first sign of pregnancy is swelling of the neck, because not only does the ovary and the corpus luteum swell with pregnancy, but the whole thyroid swells. And as you pass through menopause and the ovaries begin to slow, the other organ in the body that almost invariably will tend to slow also is the thyroid. So these structures tend to rise together and fall together, and they behave in very similar ways, and they're structurally surprisingly similar. It's helpful, if we're going to recognize these symmetries, to think about the development of them. And this applies particularly for structures in the body in relation to embryology and how we're made. And we'll talk a little bit about that as we come forwards to consider our nerves and our legs and our feet. It's also very helpful, if we're going to make symmetry seeking work for us, that we look at the long view, that we don't just look at this in the moment, but we look at this in the timeline of the body. And this allows symmetry seeking to predict certain things for us with remarkable accuracy. That if your structures are not fully formed as a child, then they will not be perfectly functional as an adult. And as you reach your elderly years, your function will step down even more profoundly than your friends and your family members. So you want to take the long view, and you want to recognize where there is a mismatch between how we're made and what we do. So we have lots of things in the body, like wisdom teeth, for example. And you think, well, what a silly thing to have given us wisdom teeth. But wisdom teeth are only a problem for us today because we eat cooked food and we use a knife and fork, and we don't have to eat bones and branches and chew on roots. Those kinds of things that our ancestors had to do would break up our teeth in the front. And our wisdom teeth were the teeth that grew in to replace those lost teeth and allowed us to survive. We are remarkably well equipped to cope with the ancient challenges of drought and famine. We are profoundly mismatched when it comes to an overabundance of calories and particularly carbohydrates, and that's part of where we struggle with things like obesity. I think the other thing that symmetry seeking is very, very helpful for is to recognize the presence of balance and of imbalance. And nature has a wonderful way of compensating for a loss by creating a strength. So that, for example, if you were to meet someone who has lost their sight, you will find that it is those individuals who have a sense of hearing that is so much better, so much more musical, for example, than those who are more normally sighted. Eyesight is probably quite a good subject to touch on because we're all familiar with the fact that many people like myself wear glasses because our eyes are not perfect. And eyesight can be all the way from 20/20 perfect all the way down to a seeing eye dog. And that kind of difference that we're familiar with the eye is also, I will show you, true of the pelvis and the pelvic floor. When we look at the human body, we're encouraged to look at ourselves from head to toe. And that may seem sensible for some things, but for the pelvic floor, it is a crazy way to look at the body. Because if we were to take the spinal cord out of the body and place it alongside the body, we'd see that as the nerves are formed and as they function like steps on a ladder. So the first nerves in the neck move the muscles of the shoulder. And then as we travel further down the body, the elbow, the wrist, and then the hand. So if you were to meet someone who had broken their neck in the usual place at C5, C6, that individual would be able to move the shoulder, move the elbow, move the wrist, but not the fingers. And if you were to meet someone who'd broken their lower back, their lumbar spine, their arms and hands would be normal, but their hips, knees, ankles, and feet would be paralyzed. The reason this is not a good way to look at the body is because the pelvic floor structures lie below the level of the feet. And this is something that is not a matter of opinion. This is a matter of fact, that there is an overlap between the nerves that innervate the feet and the nerves that innervate the pelvic floor. And of course, the pelvic floor is the foundation. It's the platform that contain and support the bladder and the urethra, the vagina, the cervix, the uterus, the rectum. And so those structures depend profoundly on pelvic floor function. And this is a part of the body that for us humans is highly, highly variable. If we look at the way that we've been encouraged to look at the body, Da Vinci's drawings, which are now more than 500 years old, draw man in a square, which emphasizes the symmetry between our right side and our left side. And in drawing the hairstyle, you'll see he's parted the hair in the midline just to sort of emphasize the similarity. And then at the same time, by spreading the legs and lifting the arms, you see man in a circle, And that implies some of the symmetries that we see because the center of the body is now the umbilicus, and the structures above mimic the structures below. The arms mimic the legs with 5 fingers and 5 toes, the shoulder girdle and the pelvic girdle. I prefer to add this form, which is man in a triangle. And we do this quite simply by folding the arms across the chest to the midline in a sort of yogic position, and by abducting the legs out to the side with the soles of the feet facing forwards. And now we are looking at the body as the nervous system looks at the body. So as we come down that spinal cord again, the shoulder is above the elbow, is above the wrist, is above the hands, and the hip is above the knee, above the ankle, and above the toes. And we can see that it is the pelvic floor that lies on the line. And developmentally, it's the pelvic floor structures that are at risk for human newborns in a way that they're not for animals. If you have a tail like a rat or a mouse, then you are immune from some of the congenital anomalies that we see in our own children. Once in every 600 live human births, the baby will have some kind of anomaly of the anorectum. These kinds of problems are unknown, have never, ever been reported in a camel or a goat or a horse or a cow or a dog or a cat or a rat, any animal that has a tail. We have to first lose the tail in order to acquire this kind of vulnerability. And in a sense, it tends to suggest that as we have grown the largest brains and the largest head, it has been at the expense of losses at the tail end of the body. This is somewhat controversial, of course. If we were to look back to the ancient Indian and Asian traditions, we find a bit of a surprise here, because if we put a square in the very center of the square and a circle in the very center of the circle and a triangle in the very center of the triangle, we are faced with a surprising, familiar picture of the chakras, the root chakra, the sacral chakra, and the solar plexus. It is these kinds of symmetries, these echoes of ancient, that add to the interest and excitement that we have about looking at the body in this way. It suggests very much that this is a way that our ancient ancestors have looked at the body before us. And if we move ahead, you know, I am a urologist, but I always called myself a pelvic surgeon, in the same way that it's the head and neck that is a surgical region, and we have head and neck surgeons. I have always, throughout my career, suggested that we should train pelvic surgeons and not, as we do at the moment, separate one kind of doctor from another in the pelvis. If we think about this cartoon where we have the bowels on the left and the uterus and vagina in the middle and the little empty bladder on the right side, you can see that in a normal, healthy pelvis, it's like the back seat of a small taxi cab with 3 passengers sharing the space. And if the bowel is not distended and if the uterus is not enlarged, then the bladder will have more space to work. And you can see in this image, as the bladder fills, it has lots of space to easily move and accommodate a large volume of urine. So Hilary, if you could move that on for me. Here we have the full bladder, able to hold and and comfortable between voiding intervals. If one of the other structures in the pelvis, for example, if the bowel is a big, lazy, loaded bowel that is taking up more space than it should, then you don't notice this in terms of bowels and bowel symptoms, but you do notice it in terms of bladder symptoms. And any of you who have experienced a pregnancy will know that in the last weeks of pregnancy, as the baby seems to be bigger and bigger, the bladder seems to be smaller and smaller. And this is not a function of the bladder getting smaller, of course, it's that the bladder doesn't have enough space to work in. And so if you were to develop a large ovarian cyst, or if you were to develop uterine fibroids, for example, the first presentation is typically with urinary symptoms rather than with other symptoms. We can look more closely at this relationship between bladders and bowels by looking at something as simple as a bladder diary. And this is a diary kept by one of many patients, but it illustrates the fact quite well that this bladder holds comfortably 400 mils of urine, and then at other times 380 and 390. But in the nighttime, between 10 o'clock at night and 3 o'clock in the morning, it doesn't want to hold any more than 100 mils. And at 5:45 in the morning, only 25 mils. And then there's an event at 7:30. And for those of you who have been paying attention, that event is a bowel movement. And as the bowels empty, Hilary, can you join us? So as the bowel empties, the bladder gets its capacity back. And this is something that's true not only of bladder function, it's also true of things like sexual function. If the bowel is full and not emptying well, then there's not enough room for the bladder. And if the bowel is full and not emptying well, there will not be enough room in the pelvis for your sexual partner. So bowel function is very important. And this is the kind of pattern that we see not in a single day, but over and over again. And if this patient is to gain relief from the constant feeling of needing to get up to empty the bladder at nighttime, the way to solve this problem is not to think about bladder medication. It's to improve bowel function. And as the bowel function improves, the bladder function will instantly be restored. This is also very relevant for patients who have intermittent bladder symptoms, who will have times when the bladder is quite good and other times when it's very troublesome, either with frequency or with leaking. And the first thing that you want to think about under those circumstances is, how is the bowel? Is the bowel working well? Is it empty, or is it not emptying well? We know that if we improve bowel function, we can help patients with all kinds of neurological illness and multiple sclerosis or spinal cord injury. It is the most important factor in dealing with children who are slow to be dry at nighttime. The best thing to do is to work with the bowel first, and then the bladder will typically look after itself. And the same is true for elderly patients or men after prostate surgery or women with urinary leakage. So as we move forwards, we have to recognize how the politics of the pelvis rather get in the way. And we've divided up the pelvis into vertical tube systems. And we've separated the bowel and the gynecological structures and the urological structures. And worse than this, not only have we divided them, but we've put a different doctor in each one of these, and their training is different and they don't talk to one another. And it makes the patient's situation in sorting out these problems much more challenging. The pelvic floor is the fundamental structure that empties the bladder, that allows you to have bladder control, that allows you to have fecal continence and a healthy bowel habit. And of course, it's also critically important for sexual function. And it is the pelvic floor that is the foundation and the platform that holds and supports all of these structures. Unfortunately, we've been very slow as doctors to truly understand the nature of the structure of the pelvic support structures. And one of the things that I have tried to do in the last 15 years is to advocate for the biotensegrity model of pelvic structure. We have in the pelvis a set of structures where everything is connected to every other thing. So, for example, if I was standing and my trousers were baggy at the ankles, I wouldn't do anything to the ankle. I would pull my trousers up at the waist and the ankles would look after themselves. And the same is true for the pelvis. When things move in the pelvis or when things prolapse in the vagina, it's not because of the local events. It's because of other things that have moved inside the body, deeper in the pelvis. And these attachments are typically best explained by the biotensegrity model. And as you look at the fascia, instead of thinking of the muscles, you think about, and instead of thinking about the bones, you think about the fascia. And you think about the nature of the fascial continuities and the 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 the, the continuity without division between one part and another. You can see as soon as we have three different kinds of doctors in the pelvis, how you divide things and you lose the nature of that continuity and you lose the opportunity to simply restore fascial detachment, which is the best way to restore normal pelvic health, not only to improve bladder function, but bowel function and sexual function all at the same time. If we go back to think about our embryology and our beginnings, there are huge variations between individuals, and nowhere in the body are those differences more marked than in the pelvic floor. And if we think about our model of our human in a triangle, you can see how exquisitely close the feet and the pelvic floor are to one another. We've already seen how the nerves of the feet and the toes are the very same nerve roots that innervate the pelvic floor. And what this tells us is that we can look at our feet and our toes, and by looking at our toes, we will see a mirror that will reflect the form and the function of our pelvic floor. And that in turn will predict our pelvic health, not only how easy is our bowel function and our continence, but also our bladder function, our relative immunity from problems like urinary tract infections, vaginal infections, and problems like pelvic pain or pain with sexual intercourse. If we look more closely at the feet, the great toe is closer to the brain than the little toe in terms of the organization of the nerves. The nerves to the great toe are proximal, and the nerves to the last toes, the fourth and the fifth toes, are lower on the ladder. And so when we look at these feet and we see that the lateral toes, Hilary, as we look at this, you see that these lateral toes are not fully formed. So this is something that has to do with events before birth. And this patient is, when asked to cough, will leak because not only are the muscles of the toes weak, but the muscles of the pelvic floor will similarly be weak and incapable of full form and function. If we move forwards and think about symmetry in terms of large and small, what we know is that it's easier to buy a pair of gloves than to buy a pair of shoes. And that's because there is a greater difference in the form of our feet than the form of our hands. And if, like this patient, the right foot is larger than the left, if we turn the patient round and look at the structures from behind, we'll find that the gluteal mass, the muscle of the gluteal bundles, is much larger, more fully formed on the right and less fully formed on the left. And this is something that you notice with your tan lines, perhaps in the summertime. But it's also something that you'll notice in the yoga studio, because as you try to do a standing pose on your right leg, this patient will be much more comfortable standing on the right than they are on the left, because the nature of the structures that they have, the architecture, is more fully formed on the right. And this is going to be true also of bowel function, that the puborectalis muscle, that is the primary muscle that helps to empty the bowel, will work much better on the right side than on the left side. And this will make the act of defecation less easy and less complete for this patient than for her sister, who might be more balanced. So there are many ways in which this helps us. And I think what I'd like to do is to turn this back to Elizabeth and see if she has any particular questions or thoughts about what we've talked about so far.
Thank you, Neil. Indeed, I do, many. But let's take some questions first from the Q&A. Michael Hall has a two-part question, and I'll start with the second part. Is there a golden ratio relationship between the kidneys, bladder, and prostate in men?
Yes, there is. These ratios are to do with mathematics. And one of the mathematics that's most familiar to us would be the Fibonacci series, where we start with 1 and we add 1 to 1 is 2, and 1 and 2 is 3, and 2 and 3 is 5. So the series is 1, 1, 2, 3, 5, 8, 13, and so forth. And if we look, for example, at the urinary tract, you have 1 urethra, 1 bladder, 2 ureters, 3 major calyces, 5 or 8 predominant calyceal systems, and so on through the body. If we look at the ratio of the distances, whether we're measuring a structure like the lung or a structure like the kidney, there is the golden ratio of relationship at every level that it has been studied. So these things that seem to be true of something like the face or the teeth or the eye, it's true of the entire body, but it's a little bit more difficult to recognize these things on the inside of the body than on the outside.
An additional question from Michael Hall. With Mozart's piano sonatas having a golden ratio structure, in terms of evolution, are we looking to develop our body towards a symphonic, symmetrical form of aesthetic beauty?
Well, that's a very interesting point. As you look to music, there are other series like the Fibonacci series. The Fibonacci series is particularly dominant in biology and in botany. But there are other additive series which are also very well studied that seem to apply a little better to musical composition. But the idea is a very straightforward one, that there are harmonious ways of doing things. Nature finds a way of doing something that is easy and chooses the easy whenever it's appropriate. One of the ways we address this in the book is to point out how many different ways there are to tie a necktie. And indeed, this has been well studied, and there's an interesting book about how many ways to tie a necktie. And I think it's 88 different ways that you can tie a piece of cloth around your neck. But in reality, there's only one or two different ways that we do it, because when we're putting on our tie in the morning, we want to use the smallest number of steps, the most economical, the quickest, the least energetic, that gives you a slidable symmetrical knot. And in the same way that nature could choose to do things in many different ways, nature almost invariably chooses the lowest energy, the easiest, quickest, simplest. And if that is the way to build a plant, it's the way to build an animal. And if that's the way to build an animal, it's the way to build a human.
A question from Annie Waite-Gilmer. In your experience, what are the consequences for someone who has very small feet relative to their height and general proportions?
Well, the form of the feet is going to be not only to do with proportion, but to do with full size. And the more let's think about buying a tomato plant. If you go to the store and you have the choice between a big tall tomato plant in a pot or a smaller, less fully formed tomato plant with fewer branches or fewer leaves, you might say, well, I'm going to choose the larger one, because the larger one has either been of a stronger type or it's been more favored with better watering, better feeding, better light, better protection from the frost, whatever it happens to be. And I think what we need to remember is that in our own human form, our time of gestation in the uterus is a time when we're particularly vulnerable to a host of different things, some of which have to do with deficit. And the most obvious one is to do with folic acid deficit. Folic acid gets its name from foliage, from fresh green leafy things. And it is folic acid that is rich in these fresh greens that is so important for developing a fully formed nervous system. And the reason that birthdays come into this business of symmetry is that if you live in the Northern Hemisphere, then you tended in the old days to eat greens, fresh greens, in the spring and the summer and the fall, but much less in the wintertime. And in the wintertime, you'd eat roots and beans and canned foods and so forth. So folic acid in the mother would be at its lowest in March and April. And it is those babies who are conceived in February, March, and April who tend to be born in November and December. And that is the reason why for those babies, there will be a tendency to have shorter fingers and more asymmetry. If you have 4 children, each in a different season, the one who tends to have problems with wetting the bed at nighttime will be the one whose birthday is closer to November. And that's a very predictable thing. And I think the other aspect of this is that although your feet may help to give you insight into your potential for full function, it can also do a great deal to minimize the stigma that is sometimes associated with bladder and bowel and pelvic problems. If you can recognize that you have these symptoms, but you also have a form of your feet that is a little different from your friend or your partner or your family member who does not have your symptoms, then it's a way of helping you understand that it is more to do with your physical form and function than it is to do with your attitude, your behavior, your psychology, and so forth.
Thank you, Neil. Continuing now on the similar theme, a question from Kathy Catalano. Do foot ankle injuries also have consequences for pelvic function?
Yes, indeed. One of the one of the things that's surprisingly common for men who break an ankle is that they will go into urinary retention. And that's because in order to be able to empty your bladder, you have to be able to relax your muscles, both on the right side and on the left side. And if you have a source of pain and tenderness on one side, that's going to tend to make the muscles more tight, more tense, less easy to relax. And that's going to tend to tip the balance. The other way in which these things are related have to do with the appreciation of pain that is oftentimes experienced by ladies in the last weeks of their pregnancy when they feel pain in the feet. And that pain in the feet is typically described as weight, that they're carrying the weight of the baby. But in reality, this is because of the stretch that's going on within the pelvic floor. And the nerves of the pelvic floor send their messages first, and then their neighbors, and then their neighbors. And the neighbors are the nerves to the feet. So the brain interprets these signals as having sore feet, when in fact it's not your feet, it's your pelvic floor. And the same would be true for your patients who present to you with foot problems. You want to always consider whether one of the triggers for problems in the feet might actually be centered in the pelvic floor.
When you look at the trends, when you look from your perspective as a clinician over decades, do you see trends in terms of effective interventions for footwork or for pelvic function that can be accessible to manual therapists or movement practitioners?
Well, there's a lot of work going on at what I'd like to think is the growing edge of these therapies. We have for many years tended to ignore the pelvic floor. And as I suggested, as doctors divide up their territory between the bowel and the bladder and so forth, you have to divide and ignore the pelvic floor. And one of the great things about the physical therapists and the body workers is that instead of being about dividing, you are about integrating and considering the whole of the structure. And in doing so, you bring to the patient lots of opportunity to integrate the nature of their problem, to include what's going on in the neck and the back and the pelvic girdle and the lower limbs and the pelvic floor, and really a lot of other things besides. But there are many things that can be done to improve the form of the feet. My advice to patients is typically to do what you can to avoid any kind of surgical intervention unless there is a very strong surgical indication and that all of the non-surgical things have been done first. Unfortunately, in terms of pelvic therapies, we have lived through a time when surgeons were encouraging patients to have quick, easy mesh surgical procedures that seemed on the face of it to offer quick, long-lasting relief. But unfortunately, we learned that the long-term consequences of that kind of surgery were quite unacceptable.
Your book is so comprehensive in terms of integrating your perspective on individual health with public health and with health or non-health supportive trends. So would you speak to not only patterns of symmetry in terms of space, but also patterns of symmetry in time?
Yes, well, we've learned a lot about nutrition, and there was a time when we used to think of food as fuel, and that is still something that one hears about. Food is fuel to some degree, but primarily food is the Lego of which the body is made. And it is by far the most important single factor in determining your health and your well-being. And I think we live in a world where there is a lot of advertising and a lot of promotion. There's a lot of there are a lot of messages and propaganda that encourages you to buy products of one kind or another. And these are largely money-making ventures on the side of the promoters. We were designed to have a mixed diet that is predominantly plant-based. And if we can eat what we were designed to eat, then we will not only improve our outlook in terms of vascular and heart health, but we will also significantly minimize our risk of chronic inflammatory disorders, including cancers. And we actually know this. This has been very well studied and well proven over the last 35 years. And yet the message just does not seem to be coming through, because there is so much other messaging that would imply that you can eat whatever you want to eat so long as you take these medications. And medications are very blunt instruments. And I am very critical of the pharmaceutical industry, and we devote a chapter to some of the problems of the current reliance or over-reliance on medication.
There are a couple of follow-up questions, one from Annie Waite-Gilmer. She thanks you for your previous answer. Could you please speak to the attachment aspect of prolapse surgery, the consequences of attachments to the sacrum? She says she plans to send a link to this presentation to clients. Annie, we just draw your attention to the disclaimer at the beginning that this is not individual medical advice. But having said that, Neil, your responses?
Well, we know very well from detailed high definition magnetic resonance imaging that if we study the normal young woman who has not yet had a pregnancy or a vaginal delivery, you can see exactly where the planes of attachment are of the fascial structures. And in the same way that in studying the limb, we used to do anatomical dissections that took the fascia away in order to see the muscle, we've been doing the same sorts of things in the pelvis for years, and we have been ignoring the normal continuity of pelvic support anatomy. We have been given the idea that we are made like a brick wall, and when there's a hole in the wall, you need to patch it. And that is ridiculous. We are not like a brick wall. We are like a continuity of network that is rather delicate. It is, because it is delicate, it's a little bit difficult to find, and you need to know where to look to find it. And you need to be able to recognize the nature of the ways in which this system can become broken and detached. But in exactly the same way that with plastic surgery after an injury, you would want your facial structures to be put back together just the way your face was before it was injured. We should, as surgeons, be trying to recreate normal nulliparous anatomy. That's to say, normal anatomy of the woman who has not yet had a pregnancy or a delivery. I think the other thing that's important to recognize with this is that as we begin to see more obviously that we are not all the same, that some are more different than others, that some have much smaller feet, that some have toes that don't move well, this has a very great bearing on whether or not your baby should be delivered vaginally or not. And in the same way that vaginal delivery can tear structures, some patients are much more easy to tear, and some are remarkably resilient and will be perfectly safe for delivery.
We'll just take a pause from the questions, both in Q&A and in the chat that are accumulating, to take a look at the slide that shows how people can order your book. Yes. So for Seeking Symmetry, Finding Patterns in Human Health, Handspring offers a 25% off the list price, and you can see the code on your screen to use at checkout. We'll also, before returning to Niall Galloway's answering your questions and speaking to your comments, we'll note that on April 14th, our guests are Robert Schleip and Jan Wilke, the editors of Fascia in Sport and Movement, the much awaited second edition of that book. Thank you, Hillary. Back to the questions accumulating here. We have a follow-up question from Michael Hall. In Taoism, they term the middle of the pelvic floor, quote, the door of death. Is energy continually leaked over time?
I am not well placed to answer this question, although I'm very interested to understand a little more about it. We tend in modern medicine to think about head first, about brains and hearts and stomachs, and we think about pelvic floors and feet as the very last and least important. In the chakra traditions and the Ayurvedic traditions, they look at the body in exactly the opposite way, where the foundation has to do with the sacrum and the sits bones. And my own career has been very much of pelvic floor first. I think that there are things that we can learn from these ancient traditions, but oftentimes as we try to translate their language, we come up with something that's not very appropriate for today. I have been interested, for example, in the relationship in the Ayurvedic tradition. The the ancients, of course, had little or no way of making ice, but they could make hot water. And they were great proponents of drinking hot. And they used to think that digestion had to do with a fire and you had to keep it warm and so forth. But we now know that ice is one of the major contributors to pelvic health problems, because the vagus nerves, which come from the base of the brain and run with the throat and travel down the esophagus and with the gut, as you warm those nerves with a bowl of coffee, a bowl of soup or a cup of coffee, it tends to make the nerves more active. It makes the bowels more active. If you cool those nerves, like all nerves in the body, they become slower and less active. And so one of the causes of constipation, particularly chronic constipation, is the chronic taking of iced water. And I would encourage any of your colleagues or your patients who are troubled with a slow, difficult bowel to move away from ice and adopt hot water instead as their typical drink. And you'll oftentimes find a very remarkable improvement in your symptoms.
From Maria Fernandez in the chat, she says, Neil is just fantastic. Wisdom everywhere, clear speaker. So much appreciate this.
Thank you.
Debbie Adams has a question. She says, thoughts on endometriosis?
Yes, well, there are a number of different conditions that we don't understand very well in the pelvis. And for the bladder, it is called interstitial cystitis. In the bowel, it is typically called irritable bowel syndrome. And in the uterus, the condition is typically endometriosis. And all of these conditions occur as a spectrum of disorder, sometimes with symptoms that are mild and sometimes very profound, sometimes changes in the end organ that are very trivial and sometimes very profound. We don't understand these conditions very well, but we do know that in the same way that when the bladder isn't working well, it doesn't empty well. When the uterus isn't working well, it doesn't empty well. The lining of the uterus should be shed through a cervix that relaxes and allows for the lining to be shed. And if there is mismatch, miscommunication, or lack of coordination between the contractions of the body of the cervix and the opening of the cervix, the body of the uterus, the contractions of the body of the uterus and the opening and relaxation of the cervix, then you increase the pressure within the uterus, and that tends to drive the fluids backwards up the tubes and into the pelvic cavity. And there, those cells can seed the inside and they can cause lesions that can bleed, and they can become adherent and stick things together, and they cause a lot of problems, including infertility problems. We have the same sorts of problems with the bowel that is typically starts off as either inflammatory bowel disease or irritable bowel syndrome, and will oftentimes lead to problems like sigmoid diverticulosis, which can be a surgical disease. So from my point of view, as an embryologist and a developmental biologist, I could draw for you how exactly the same is the structure of the lower urinary tract, the genital tract, and the bowel system. They're all made the same from the same cells. They're nourished by the same blood vessels. They're innervated by the same nerves. And so if you happen to be troubled by endometriosis, it will be almost always the case that you're also troubled by some form of symptoms, both in the bladder and in the bowels.
The questions continue regarding pelvic function and dysfunction. Are there any symptoms in pelvic dysfunction that would require the Kegel exercise?
Yes, Kegel exercises were popularized by a Californian gynecologist. And basically, these involve strengthening the muscles of the pelvic floor by gripping. And these are very well described, actually. If you would like to find a place online to find Kegel exercises, I would recommend the site of the National Association for Continence, nafc.org. They have a wonderful section in their website about Kegel exercises. The paradox with Kegel exercises is that most people who have normal muscle strength and normal anatomy do not need to do Kegel exercises. And the ones who need the help because they have symptoms are often the ones who have muscle weakness. And it is much more difficult to strengthen a weak muscle than it is to strengthen a muscle that is not already weak. And of course, in the pelvic floor, there are degrees of deficit such that some patients have no muscle at all. And they're the ones who have the very worst of symptoms. And they're the ones who sometimes are directed to do exercises where the exercises have absolutely no chance of helping the patient because the muscle structures are just not strong enough. So, for example, if you were to take such a patient and look at their feet, and if they were completely unable to abduct their toes, to open their toes in the line of the toes, that would be a marker that Kegel exercises are very unlikely to be helpful, but will be very frustrating and time-consuming and for no benefit.
We have a comment and a question that comes from the chat from a participant. I have an indirect and a direct inguinal hernia on each side. I have been told to have surgery with mesh, as without mesh it is not very strong, so will need to be redone. What suggestions do you have, including nutrients, to reinforce the connective tissue?
Well, in a typical situation like this one, where there are hernias on both sides, this typically follows multiple pregnancies, where the pregnancy has led to distension of the tissues and the structure. But now that the pregnancies are past, there is no strong indication for treatment unless there is a situation in which the hernia will allow a knuckle of bowel or some other abdominal contents to become stuck. In the typical situation, if you have a hernia on the right and on the left, it's less likely that you're going to get into trouble. And it's more likely that you're going to gain benefit by doing things like giving more attention to your diet and your bowel function and your weight loss. And if there's any degree of abdominal distension, by eliminating the abdominal distension, that will go a long way to helping. The concern with mesh is that mesh is a permanent product. And although mesh can be chronically painful in the setting of a hernia repair, it was particularly inappropriate in the vagina because the vagina is a territory like the mouth that can never be sterilized. And so you cannot do a vaginal surgery and place mesh and be guaranteed that there will not be an infection. I think it would be very important before you are going to take the advice of a single surgeon to get a second opinion, because It sounds very much as if there is a lot of non-surgical help that you could have that might avoid the need for a surgery.
Also in the chat is a question regarding the relationship and timing of bowel movement and urination. There's a curiosity that if someone is simultaneously having a bowel movement and urinating uncontrollably, or has to have the bowel movement first in order to urinate, what comments do you have regarding where this questionnaire could look for treatment or for more information to guide?
Well, the typical thing in nature is that you either empty your bladder or you empty your bowel. And to do both things at the same time is surprisingly common for patients who do not have versatile pelvic floor function. Under normal circumstances, let's say not normal, but ideal circumstances, the bowel should work like the railway. And when the bowels move, the whole train should leave the station. And you know whether you have performed well because you do not need to wipe your bottom afterwards. This idea that humans need toilet paper is a reflection not of normal human behavior. It's a reflection of the fact that most all of us have a somewhat imperfect pelvic floor function. If you think about it, you know, you can buy anything in America for your pet, but you can't buy toilet roll because cats and dogs don't ever need to have their bottom wiped because they have tail structures and they have a different kind of pelvic floor. And when the bowels move, they move, leaving the rectum empty. If you find that you have to use a lot of toilet tissue to be clean after a bowel movement, that's a reflection of the fact that when the bowels have moved, cars have come off the train, a little bit like the toothpaste tube, that you've been able to push something out, but the bowel is not empty. And for health, you want to try as often as possible to actually empty the bowel, leaving the bowel empty. And if needs be, that can be done with the help of a suppository, either a glycerin suppository, a simple jelly suppository, or a suppository with medication. You're going to find that bladder and bowel go together. The pelvic floor is very economical. When the bladder is empty and the bowel is empty, the pelvic floor is relaxed. But when the bowel is more full, the pelvic floor becomes more recruited, and that recruitment increases the tone and the activity, not only in the pelvic floor, but also in the sphincters. So for patients who have a loaded bowel, you're going to find that you're not able to empty your bladder well until the bowel empties first. And that creates the situation where you might sit to empty thinking that you're going to empty your bladder. You empty a little, you then have a bowel movement, and you empty a whole lot more from your bladder. These situations are physiological, they're very understandable, and they're very readily treatable. And the way to address this is to treat the bowel first. And you do that by choosing your diet and by working on the other simple measures.
We also have a question in the chat. Can you talk about the relationship between breathing and pelvic floor function?
Well, yes, you know, breathing is the act of ventilating your lungs, and those functions are largely controlled by the gateway, which is the larynx. And the larynx, of course, is the voice box in the neck. And if you were to think about it for a moment, the events that cause leakage from your bladder are events typically coughing, laughing, and sneezing. They're all laryngeal events. And what happens with the larynx mirrors what happens with the urethra because they're made the same, they're organized the same, and they're integrated the same way. So, for example, breathing and swallowing are very closely integrated. It is difficult, impossible, to be breathing and swallowing at the same time. You're either breathing or you're swallowing. And the same is true with the bowel and the bladder. Typically, the two don't work at exactly the same time. The other thing that we now know that we didn't know 25 years ago is that the systems crosstalk to a remarkable degree with one another. So, for example, if you have a chronic cough, we now know that chronic cough is often associated with gastroesophageal reflux, that it's nothing to do, perhaps, with the larynx or the trachea or the airway or the lungs. It's to do with the neighbor, which is the stomach and the esophagus. And if you go to a lung specialist, you can have a lot of testing that all turns up negative because we're looking at the wrong structure. And this is very like the familiar situation that some of you have with young children, where you're traveling in the car and there are two small children in the back seat, and one of them is terribly fussy and the other one is nice and quiet. And you look in the mirror and you see the quiet one is making the other one fussy. And this happens in the body. It happens particularly between the esophagus and the airway, and it happens between the bowels and the bladder. And so you want to always look in the rearview mirror and check out everybody on the back seat and not just think, if this is a cough, I need a cough suppressant.
Niall, thank you very, very much for your generosity with your wisdom, your comprehensive understanding of human health. And we didn't even get to many, many chapters in your book that speak about the trends in global health and public health that are so relevant to our individual health. So I very much look forward to the next webinar.
Well, thank you very much indeed for having me today. It's been a real pleasure.
Let's take a look at the slide for Niall's book. Thank you, everyone.